It's modified MIGS she is going to present.
This video describes a new technique of modified MIGS wherein two trabecular bypass procedures have been combined to attain effective IOP reduction in traumatic glaucoma. A 37-year-old patient sustained blunt injury with a cricket ball 2 months ago. His visual acuity was 6/6 but had chronic IOP elevation of 60 millimeters of mercury in spite of maximum anti-glaucoma medications including mannitol and even paracentesis. His optic nerve head was normal and so were the visual fields and RNFL OCT. He had angle recession in the superior quadrant. Chronic IOP elevation post-blunt trauma has been attributed to damage and fibrosis of the trabecular meshwork and collapse of the Schlemm's canal, both of which decrease the aqueous outflow. Here I have combined an iStent inject implant with a limited bent ab interno needle goniectomy. The iStent serves to bypass the damaged trabecular meshwork and is placed 3 clock hours apart. Limited bang is then performed for 2 clock hours in between the two stents. The rationale behind this is to viscodilate and expand the Schlemm's canal behind and around the stents so as to facilitate the outflow. Long-term outcome of this technique is still to be assessed, but achieving this whopping decline in intraocular pressure without having to deal with the potential risks, complicated follow-up regime and longer recovery time, and yet sparing the conjunctiva for any future filtration surgery was a blessing for this young patient. Here you see 2 well-placed stents and a well-dilated Schlemm's canal. There were no complications encountered and the patient's post-op intraocular pressure was 10 millimeters of mercury on 2 anti-glaucoma medications.
So what's the carry-home message you're trying to tell?
So first of all, I really want to apologize for being late. I was stuck in an IC, and thank you so much for waiting. Thank you so much for the opportunity. So now this case, what is novel in this case is that, let's remember, this is a young patient, a 30-year-old patient who had a pressure of 60 millimeters of mercury. So the only option one thinks of is trabeculectomy in this patient, which nowadays becomes, sounds like a very aggressive treatment because this is an ocular hypertensive. He does not have any glaucomatous damage. So now with the introduction of MIGS in our surgical armamentarium, we're able to give them that benefit of saving them from the trabeculectomy and also bringing down the IOP reduction, which the anti-glaucoma medications cannot. What is different about is this case is that I've combined 2 MIGS procedures which have normally been done separately. And why I did this was that repeatedly I was seeing if one procedure fails, you jump in to do another MIGS procedures. Now, iStent and bang, both they have their own demerits. iStent takes a little, because these are really tiny devices, it takes a long time for the aqueous to flow in through this and the Schlemm's canal to expand. So it takes a while, and leaving a pressure of 60, giving them the window of taking 2-3 months for the pressure to stabilize was not really fair to the patient. The demerit with bang, which is trabecular stripping, is the fact that let's say after 2 to 3 months, they do develop some sort of peripheral anterior synechiae because this is not a very sophisticated stripping of the trabecular meshwork, so it seals back. Now, when that happens, of course, the IOP rises. So now, rather than doing iStent and later on, if that fails or takes time, doing a bang or vice versa, what we did was we combined the 2 procedures, saved the patient from a trabeculectomy and also maybe another MIGS procedure if that was required. Gave them the benefit that bang will immediately drop down the IOP because there is a large, at least let's say 50 to 60 degrees of communication of the aqueous into the Schlemm's canal, and even if it seals later on a few months down the line, the stents by then would have kicked in. So that is the advantage that we've given, and I have a follow-up of 8 months with this patient, with the pressure is maintained at 15 millimeters of mercury with 4 anti-glaucoma medications.
Was it a case of angle recession?
Yes, sir.
How much?
So angle recession was about 90 degrees, the entire superior quadrant, and a little more than 90 degrees. The target area of MIGS is always nasal, and that angle is spared. Of course, it would not have been attempted if the angle recession was in the nasal hemisphere, and if that's where the bang was to be performed, it could not have been done.
Because it should be done away from.
Yes, yes. So it was superior, the angle recession, and the treatment area was nasal. Thank you.
Thank you.